Hey, good morning, everyone, and good morning to our online audience. Magic's going to send a message saying good morning, but good morning, Peter Foster. It looks like you've been ready, and we're, as you said, ready to shake, rattle, and roll. We're going to do that for sure this morning. I think this is going to be a very interesting program for you, but let me first go through our standard opening remarks, if I may. Of course, I'm Joe Basha, your host of PerfWeb, and normally I'm joined with one of my co-hosts, which is, of course, Samir Patel, physician and perfusionist extraordinaire, but he's not here today. He's going to be doing some other things. You can come up to contact us at our guest speaker is here and getting ready to sit down. There you go, walking in front of the camera. I love it. I just love it. We got a good view of the top of your head, bro. It's good to see you this morning. Contact us at perfusioneducation.com right there. You'll see our Chiron crawl, whatever they call that thing, going around down there every once in a while. You go check our MediWeb app out. Of course, that's really a great app. And then our PerfWeb podcast, you can go to whatever your favorite streaming software is, and you can listen to us all over the place. And let's see, Peter said something else, I think. May this stream be profoundly blessed. May there be absolutely no technical issues, and may we learn a tremendous amount today. I did send you an email this morning quite a bit earlier with some questions about simulation. Oh, yeah, okay. Peter, I did see that, and we're going to take a look at that. Thank you very much for joining us. But let me introduce to you your panel, extraordinary panel for this morning, if I may. Over there to the far right is Austin Sullivan. Austin has been with us for, I don't know, 15, 16 years, something like that. Has it been that long?
12, I think.
12 years. It seems like 16, sometimes seems like 60, to be honest with you. But nevertheless, he has become our administrator, our supervisor, director of auto transfusion and perfusion assistant division. And he's also on the perfusion assistant division of our NRP program that we have here, the service that we provide. So HET, of course, you know, is the part of the organization that we use to basically earn money to pay for this endeavor. And this endeavor is really just intended to be a information sharing education program in perfusion and other things with the mission of bringing kind of real world in the trenches. There's evidence-based stuff too, of course, but a lot of it is anecdotal and experience and being able to talk about things that we actually see and not necessarily just the theoretical aspect of it, though both are critically important. Obviously, you have to do both. But let me introduce to you our guest for today. Our guest for today is my good friend, Clark Milliken. He hates public speaking and probably hates even more the idea of having to sit here on camera and be out there in web world, knowing now full well that there are actually people paying attention and watching this program. It could be millions. You know what? Let me tell you something, Clark. Clark is a perfusionist. I mean, he's been a perfusionist for over 35 years, right?
33.
33 years, yeah, 33 years. And he's the only now you don't have I have more years in perfusion than you do, but in terms of the company, in terms of your place in the greater community of humanity, you are senior to me. You technically are, right?
Yes.
And after I tell your story today, I think everyone will understand that, I did everything I could to keep you, where you are, but maybe there may have been a bubble or two around somewhere. And see, you never laughed quite like that. You laugh a little more frequently now.
Well, thank you for having me here, Joe.
Yes, no bubbles, no troubles. You know what they say.
Right.
But what's a little air among friends?
That I've heard that one before.
Exactly.
Yeah.
But I wanted to tell you about his. If I may, let me just tee this up for you today.
Please.
And Austin was there. The fundamental rule in our industry is that, one, you don't want to ever do a case of somebody that you know really well, and especially not a family member. but you also, and he's part of my extended work family, right? He's not technically a family member, but you know, we work together pretty intimately and have for a number of years. But the second rule is you never do anything any differently than you would for anybody else. That's the rule. I can tell you all right now, that's not what happened, okay? And the reason that you're supposed to do that is because once you start doing things differently, for whatever reason, inevitably something's not going to go as expected. There's always a problem. But what the first thing is that there was myself there was Becky there, that's two perfusionists doing one case, on a case that really should have only been one perfusionist. I call Austin up and I say, Austin, you're doing this case because I don't want somebody else there. I want somebody that I know knows what they're doing, and if I need help, they're able to help me. So from the very beginning of this whole endeavor, everything was different from the very start. I wanted to do the case. I actually did, surprisingly enough. I actually did want to do the case. And that's simply because of my, I guess, inherent arrogance that there's no one that was going to do your case better than me. I mean, it's crazy to say that, but, you know, if I were just really going to be completely transparent, I'm always honest. But if I were going to just be uber honest, let's say, because you can be honest without being like, you can be almost completely honest. You always got to hold a little something back. And, you know, and of course that brings up a separate issue, which is if you don't have any swag, if you don't think you're the best at what you do, what the hell are you doing this for, right? Is that not true?
I think we all have a level of confidence like that.
I think we better have it. Yeah, I think you have to have it in this, whether you're a heart surgeon, whether you're intensive care medicine, cardiology, perfusion, critical care nursing, operating room nursing, anesthesia, you know, CRNA, let's say in a trauma center. I mean, if you don't think you're the best, if you don't look at a situation and say, oh, I would have done that differently, I would have done better with that, I should have been the one doing that case. If you don't have that kind of attitude, then I don't think you should be in this industry. So anyway, make a long story short, and of course, you know me, I'm very good with long stories, and terrible at making them short. However, with that said, it's all perspective, okay? It's subjective what is short. But I get a phone call, and it's Clark's wife, lovely wife, Diane.
Right.
Clark is in the emergency room. He had cardiac arrest and was resuscitated, and I'm on my way to the hospital, and that started my morning off.
Oh.
Okay, that's the first thing I hear. So it was rather like, oh, you know, goodness, because I knew you were on your way to the hospital to do a case.
Right.
So you're a staff member of mine scheduled for a case, and now you're in that very same hospital's emergency room having had a cardiac arrest, and none of us at that point in time, I didn't, and I don't think Diane did either, knows whether you're going to survive this or not. Correct. So it was very emotional and chaotic, to be completely blunt, right?
Right.
But I have to also put on this other hat. And not only do I have to worry about you, and I am then getting that direction to figure out what's happening here, I know I have to get somebody in there to do your case.
Right.
Because there's still another patient in the operating room waiting to be done.
That's correct.
So now I've got that going on top of everything else. So, and I'll tell you something, Clark. I'll tell everybody kind of your history a little bit, if I may, and if anything that you're not, I don't think I'll say anything you wouldn't be comfortable with, but if there is anything, just sort of, you know, just interrupt me in the middle of it. But I didn't discuss it with you ahead of time, and I apologize for that. But, you know, you shouldn't be here. To be completely blunt with you, dude, you should not be here. Somebody with your particular anatomy, I would say 95% chance of mortality. That's your mortality risk. So Clark's problem was that he had, well, I'll tell you what happened. So he's walking across the bridge. He probably remembers that. He gets across, now this dude was going out and walking 1.5 miles every day, out in the woods by himself. Okay, he was playing tennis, but he recently stopped playing tennis because he just thought he was getting old and tired and just didn't have the same, I guess just part of the aging process. So you would kind of stop the tennis because tennis was a big deal for you, right?
Correct.
But you were also carrying a grill up the stairs in your home to the balcony where you would grill for you and Diane and maybe your kids if they came over or something like that.
Propane tanks.
Propane tanks, yeah. And propane tanks, what are they, like 15 pounds, 20 pounds?
Probably a little more than
A little more, 50? So you have good-sized propane
right.
tanks.
5
5-gallon, yeah. So, I don't know what propane weighs, 6 5s or 30, probably 30 or 40 pounds, yeah.
Right.
I don't know the weight of propane. Gas is like, gasoline is 6 pounds a
I
gallon.
would say 30, 40.
30, 40 pounds, yeah. And carrying one or two?
Just one.
Just one, thank goodness. Okay, good. That's good. I figured maybe you were just kind of doing like this with them all the way up the stairs.
No.
But so he's crossing the bridge. Somewhere along the way, he either decides he wasn't feeling well, or you decided that you just needed to use the restroom, or I don't really know what was going on in your mind, so we may ask you that question. But the next thing is somebody sees him, thank God, go down. And they go over there. And he is pulseless. He is dead. And they immediately start CPR. And he has ROSC. So they were able to get him back. And off he goes to the emergency room. And that's what the call is. Now, why I say what I say is because Clark had both aortic stenosis and a single discrete lesion in the proximal to mid LAD, which was 90% or maybe a little bit more. So we all know, perfusionists know, the hardest heart in the world to protect is aortic stenosis and CAD. Hardest heart in the world to protect. But more than that, it's the hardest heart in the world to do effective CPR with, because you have this obstruction out the aortic valve. Now, try to picture this in your minds, because a gradient of 5 is an addressable issue. A gradient of 20 is considered significant. A gradient of 100 is considered extreme. And your gradient was 113 millimeters across his aortic valve, plus a 90+% occlusion of his proximal to mid LAD. So with that said, Clark, if you would be so kind, take a few moments and sort of just tell people what you remember as best you can.
Wow. It was about 6 months ago. I'm going in to do an early case at Methodist Hospital. And I walk in across the bridge between the parking lot and the hospital. I'm talking with a coworker. We're talking about our case. He splits off to go to the ICU. And
Who was it?
It was Jeff Turnbull.
Jeff Turnbull, okay.
A PA that, very nice guy, worked together for years. And he splits off to go to the ICU, and I have a syncopal episode and just kind of slide down the wall. And I actually got back up thinking I just needed to go to the restroom, and never made it there. Woke up to people hovering over me doing CPR. And it was surreal. You never think that you will be on the receiving end. They don't teach you that part.
Oh, no. No. I don't know what I would do. We'll talk about that as we move forward. But please,
Right.
let me just tell the story.
So I wake up laying straight on my back to, people doing CPR on me, and I wake up and look down, my shirt split down the middle. I have defib pads on, and everybody's. I'm trying to get up, and they say no, just lay down. We're going to take care of you, and so all the communications go on from there. But I get whisked off down to the ER, and there the crew start the diagnosis of what's the problem, what's going on, and I find out I've had a bicuspid valve my entire life and never knew it. I've done a fair amount of athletics my entire life, and never ever had that diagnosed. I had a flight physical in the Navy, never diagnosed.
You would think you'd have had some kind of murmur,
Right.
a thrill
Right.
or something, some kind of
Right.
something.
Right. Right. And I just think at times of exertion, I thought, well, I'm just getting a little older. Before that, it was like, just train a little harder.
Mm-hmm.
So that threshold got narrow enough to the point where it just said this is enough,
Mm-hmm.
and I fell,
Yeah.
and that's kind of where I was.
Yeah.
Yep.
The girl that did the CPR, she was a cath lab tech,
Mm-hmm.
and she was a big girl. She's a big girl, and you needed a big girl.
Yeah.
You definitely needed a big girl. Okay, you needed somebody who was going to listen. I have no doubt in my mind that the backside of your sternum hit the backside of your spinal processes. There's no question about it in my mind, okay? Because I think that when she pushed out on you, you literally collapsed into just a pancake and popped back out again. Because that's what got you going. Because you shouldn't be here, dude.
She's a very, very sweet person, and I come to find out she used to be a bartender somewhere downtown Houston, but she's
Scrappy.
yeah,
Mm-hmm.
yeah, she's got the oomph,
Mm-hmm.
but very sweet, very sweet.
Mm-hmm. So I have some questions for you if I can, and Austin, please feel free to just chime in or whatever if you'd like to while we're doing this. But so by the time I got there, you were in the emergency room.
Right,
You were awake.
right,
You were lucid.
right,
We were still waiting on Diane to get there.
right.
What was going through your mind?
Well,
You hadn't made it to the cath lab yet.
right. No, as a matter of fact, we were in the ER, and the first diagnostic process, of course, was a portable cardiac ultrasound
Mm-hmm.
that they did. But yes, when I was after I woke up, I felt just like I did before I walked in the hospital. I was asymptomatic.
Mm-hmm.
I didn't have chest pain. All my labs were normal. My blood pressure was normal.
Mm-hmm.
So it's quite remarkable to think.
And you
that-
really didn't have that EKG changes.
I know, no EKG changes. So yeah, it was very surprising to learn all of this, surreal. And the way you feel inside as a professional, we do this every day, and we see all of the good and all of the other things that can go on. And we know, and we've learned, and we've studied about all of the what ifs. But these are the things that are going through your head. You know, now I'm the subject. I'm not the caregiver. And so that puts a totally different perspective on the situation. And that's where I was. You know, you're torn about what your decision-making process will be. And, you know, God was just not done with me yet. And so
Thank God, because you know we still got cases to do, and we still need your help. Okay, I have to be completely transparent, Clark. You know,
Right.
I love you personally, but
Right.
man, I can't afford to lose any staff right now. Okay, so we really appreciate you.
Well, you know, Joe, I can't say enough about you. You know, this guy, you know, was there even when I wasn't needing him as a professional. He was there as a friend. And I can't say enough about that.
Well, thank you. That was very kind of you. So that was very kind. Thank you. So I want to ask you, you know, because obviously we find out that you have not only a bicuspid aortic valve, but you have a severely calcified aortic valve. Your annulus was just a boulder field of calcium. It was unbelievable. I'd never seen anything like it. Interestingly enough, I have seen one other aortic valve that had a bit of a higher gradient. It had 120 millimeter gradient. I still have pictures of it. Yours, though, was 113 millimeters of mercury, 113. So if your blood pressure was 120 in your radial artery, it was 233 in your ventricle. And your heart was still, it was still not completely remodeled. It just was so interesting to see what seemed to be a pretty normal heart. Now, you had some not insubstantial LV hypertrophy. Your LV was thick, and that was something that had me really concerned for when we did your case.
Right.
But you also had to deal with two opposing viewpoints. Do I do this surgically, or do I do this as a TAVR and a stent?
Right.
What am I going to do here?
Right.
Now, I will admit that though I did everything I could to give you objective opinions about things, I don't think there's any question that I was a lot more supportive of surgery than I was TAVR. I really didn't think TAVR was a good idea. But I tried really hard to not say to you, Clark, don't do a TAVR. You had to make that choice on your own. And I tried to, to give you my opinion without it being too forceful, I guess, in that opinion and make it even more difficult for you to make a choice. But can you talk to us about kind of how you ended up making that decision to go ahead and go with surgery? And if I may, if you don't mind my adding this, I feel 100% confident that if they would have TAVR'd you, you were going to die. I do believe that.
Well, when you look at the overall situation, I had, like you said, circumstances that pointed me in that direction. The amount of calcification, the possibility of aortic rupture, because they would have had to balloon my aortic valve just to pass the delivery device.
Correct.
For a TAVR. And with the amount of calcium, I've sat through TAVRs before that went bad.
Oh, yeah.
And were fatal.
Oh, it's a fatal injury.
Right.
They say they say there's a few that get saved, but I don't believe it.
It's hard.
You might get saved in the moment, but you're not saved.
It's hard to recover a ruptured aorta in a closed chest.
Mm-hmm.
I mean, the time. Now, I don't care how good the surgeon is and the cardiologist. It's a big ask. But that weighed in my decision. Plus, the two-stage potential of repair, I think also weighed in my decision. Knowing that I was where I could trust people, and look, I love the people I work with, and I have an extreme amount of confidence in the team that was there. So there were no reservations there. That kind of eliminated any negative other than recovery time for the surgery. So after my cath and I found out my coronary status, it was a no-brainer. The decision became easy.
Yeah, it's always interesting to me to hear perfusionists that realize I'm going to have to be put on bypass, something that we do every day, and who's going to do this case? Yeah,
Well,
it's
we
stressful.
know too much.
We do.
Yeah.
We do. We do. We truly.
Yeah.
We do.
Yeah.
So let me drag Austin into this conversation if I can. So remember what I said. The number one rule is don't do anything differently. Right? You technically shouldn't have been the person scheduled for that case. And again, we generally operate with one perfusionist, one assistant, pretty much on a daily basis. But in this particular case, you get a phone call from me, and it's like, I don't want anybody else scheduled for this case. I want you doing this case. I need the best person that we have to do this technically. I'm not giving you any endorsements otherwise, other than your technical skills, so don't get too excited over there. I still have some issues with you, but regardless of that, what went through your mind?
I wasn't sure.
Besides, oh hell, I don't want to work. I don't want to have to work with Joe. You could say that too if you want to.
Of course, no. I didn't know who the patient was. You didn't tell me. You hadn't told me who the patient was, so I wasn't sure. I knew someone high profile, perhaps, or it was a case that was extremely important to you. That you and Becky were on the case, and you wanted me on the case. So I was just excited to be there to help the best I could. But it was interesting once I found out eventually, of course, who the patient was. I had worked at Clark many times in the past, of course, and developed somewhat of a good working relationship with Clark. And so I was surprised, and it's emotional to see Clark in the operating room and stuff like that. So I wasn't expecting that for sure, it to be Clark, but I knew something was going on for sure. That was going to be a high-profile case, more or less.
Well, it was certainly extremely helpful to have you there because, what I say, we don't do anything differently. And of course, we did everything differently, Clark. I just have to tell you, okay, everything.
It's hard not to.
And we there was a hiccup or two, not on our end, but there was a hiccup or two, and we needed, I'm glad he was there. All right, that's all I can tell you. And I was glad Becky was there too. So, ultimately, we do the case, we go on pump, everything is going great. I worked harder than I normally do at getting the bubbles out. But I know I left a few behind, but that's okay. Diane says it has really helped with your personality. She says, I don't know where those bubbles went to, but they obviously went to the right place. Tried to give you the best flow we could, but really at the end of the day, I think the pump run itself was essentially the same. I think that part was the same, but I can't deny I had an increased level of apprehension. I definitely did. There's no way I could have ever just really been my usual self, completely disconnected from, who this person really is. Because we really don't, perfusionists don't really, we don't talk to patients before surgery. I mean, they can roll in and I jibber jabber a little bit with them, or I try to have some kind of, and on rare occasion, I'll kind of walk around and see them in the, where maybe the surgeon is talking to them and giving them their final consult, but writing on them, whatever they do, before the operation is going to be done. But by and large, we don't know these people, right? They're just It's just patient X. They have a name, but we know them by their MRN, right? Pretty much, and just make sure that you scan the right sticker for them. We did do that on yours. We didn't have any sticker mishaps. Although I have to tell you that Diane had shown me these labs, and I was looking at these labs, and your troponin was bumped. I don't know if you remember this or not. And looking at them, but then somewhere along the way, I kind of looked it over and I was like, where'd you get these? I asked Diane, well, where did you get these? And she says they were sitting over there. I said, okay, well, they're not his.
They were from another patient. Yes.
Yes. Yeah. And when you came, with the chaos of you getting in there from this arrest, it just got thrown on the desk, and Diane, of course, being Diane, picks it up and she starts looking. And she just shows me the lab numbers, and I was like, "Man, he's had a heart attack." I mean, he's had a heart attack. And then I'm like, "Well, who is this? Somebody better realize somebody else had a heart attack. I hope we get to the right person." And so we had that, and then. But the case went well. I was impressed at the amount of work that had to be done to get your annulus suitable for having sutures put in it, and we were all talking that, man, there's no way this TAVR would have ruptured. It was just so rock hard. It was incredible, and I was really worried about it. Even just being able to get the valve in, not have a paravalvular leak. And
spare enough tissue.
Yeah, and
right.
you weren't going to be in complete heart block. They
Right.
weren't going to do something and bag, your mitral valve, the posterior leaflet, having some kind of or I guess anterior leaflet would be the one, right, that would get bagged. It just any kind of problem. Right. And so and just whatever. And so I was worried about that, but it wasn't until the LV vent in the right superior pulmonary vein came out, if you remember that. And then there's the bleeding, And, but they did get that under control fairly quickly. But again, you were critically in that situation because we had a lot of blood coming back to the cell saver in a hurry. And that was problematic. I was concerned about that with, hey, you really need to use these pumps up, but they couldn't see. And so, fortunately, that got
those
fixed.
things that we think about, that could happen that don't normally happen.
And as a result, we had to transfuse you,
Right.
which I did not want to do. I was irritated as hell at that,
Right.
but we had to.
Yeah. Yeah.
So there was definitely that hiccup.
You didn't give me any wokey blood, though, did you?
No, I didn't give you any of that. No,
All right.
no. Actually, we found out that Austin was your same blood type, good match, and we bloodlet him real quick. Okay, we weren't waiting for the lab. We just did cross circulation, and we just pumped it right out of him into the pump on vacuum assist.
Right.
Yeah,
That's why it went so well.
exactly.
Austin and I talked earlier about situations similar to this, where, if you're a perfusionist for long enough, you are asked to do an acquaintance or a family member or requested.
Yeah, you've done a few request cases. I know you have.
I have. And I was sharing with Austin, I actually did a neighbor where my kids still stay in touch with their kids in adult life. I mean, that's how close we were as neighbors. And she had an issue. You try your best, as we're taught to focus. And you don't lose the idea that there's a person in there, but you do try to concentrate on your job and stay focused with the cues that, we go through. But it's hard. It's extremely hard because you are always in the back of your mind thinking, this is that person that I know. This is that acquaintance. This is that association. And this particular person tried to die on me 3 times, but is still with us today. And this was like 30 years ago.
That's amazing.
Yeah.
Was it a valve or was it coronary?
It's coronary. She had extreme coronary issues.
I mean, for them to last, isn't it amazing? 30 years.
Right.
You know, and you just brought up something else that's so interesting, because, you know, how many times do we hear that, oh, stents, you know, 30 years, tried and true operation. I mean, we're talking valve cabbage in your case, but just talking about coronary artery bypass grafting, okay?
Right.
Typical cabbage case.
Right.
All right. The durability of that, if you have a good surgeon
Right.
and those anastomoses are good and you have good runoff and everything else, but if you don't have good runoff, then the same thing's going to apply with interventional stuff like stenting and things like that.
Right.
But you're much more likely to need another procedure to either open a closed stent or something else, you know, whether it be in-stent stenosis or post-stent stenotic phenomenons that occur. And then you have these vessels that are essentially with kissing stents going all the way down them and essentially jail them, so that if you do decide to have have bypass grafting, you can't do it, right? And but tried and true operation, coronary artery bypass grafting. We do it every day, and we think to ourselves, man, if I needed surgery, if I had coronary heart disease or atherosclerotic heart disease, what would I do? Would I do bypass surgery or would I do stents? What would I do? And the data is that bypass grafting is better, but most people will pick stents.
I think it's recovery time. I think that's what's in the back of their mind.
Yeah.
I think that
And not having their sternum open.
right, not having their sternum open. I spoke with Austin this morning about my scar is so nice. When they closed me, they used a closure device that has the plates in it.
Yep.
And
Your sternum is stable.
right,
And that was because you're athletic.
there was no instability at all. I haven't had any sternal pain. My reserve is so much better. I will say that it's remarkable to me that we know surgeons who have had stents.
Yes. Yes. That's true. That's true.
Yeah.
Yeah. That is true.
So what drives them? You know,
Yeah.
because and these are not terrible surgeons. These are good
No,
surgeons.
it's very good. Yes.
Yeah.
I know, man. It is. It's just it's so personal. It's just so personal, you know. I'm going to try to call Becky and see if I can loop her in, since she did the case with me and we were there at your Heart Hero event.
Yes,
Okay, which was a
yes.
big deal, I thought. I don't have any pictures of that, but at least not on my computer. But we could talk a little bit about that and how you were recognized
Sure.
at the hospital, and maybe even talk a little bit about the hospital. So I'm going to try to call her. I don't know if she'll answer. She's on vacation.
Right.
Oh, I have to share my computer? Oh, okay.
Yeah. Becky, bless her heart.
Screen mirroring? Yes. Screen mirroring. Joe's iMac? Yes. Let's see, did it go through? How cool. Well, she might answer.
Sorry I missed your call. Get back to you as soon as I can.
Oh, she didn't answer. I'll try calling her again, because sometimes I'm going to try to call her. I don't know if she'll answer. She's on vacation.
Right.
Oh, I have to share my computer? Oh, okay.
Yeah,
Sorry about that. I know. You know, you can't. You can dress me up, dude. You can't take me anywhere. It's sad. There, try one more time. Is it ringing? Yeah. She answer? No, I don't. I muted YouTube.
Call has been forwarded to voicemail. The
And I
person you're
unmuted
trying
it.
to reach is not available. At the tone,
Okay. So Becky's not going to answer, but that's okay. So Austin, at the end of the day, you know, you obviously are coming at it, but you didn't know who it was going to be. You're there doing the case. What was going through, you know, besides everything else, just basically doing the case? Did you have any apprehension? Did you have any You know, were you more, do you feel like you were more involved than you would be on any normal given day? Do you feel like you did everything the same way as you would normally do it? What's your opinion about this? What do you think?
I think with the support of you and Becky there, I was actually a little relieved because we don't have that much support in each case. And, you know, we had two of the best perfusionists in our group there
Well, that's
together.
awfully nice of you to say.
So I was, you know, I kind of treated it like, try to treat it as every other case. I guess weirdly to say. Everything okay? Mike?
Yeah, just push it
Towards me? Sorry.
We have to get new mics.
Oh, okay. But I try to treat it like every case. I think it was pump run was straightforward. It went really well. Besides the hiccup of the bleeding, everything else went really, really well. But I mean, I think we were all more focused a little bit, just because you know, we know Clark, of course, and but I also feel you would have acted that way no matter who was on the table, you, Becky, and I. So a little of both, I guess.
Now, in our system, the way we do our system, right? And you, of course, I don't, you know, it's funny because we work together, but we don't work together, right?
Right. I think
And-
all perfusionists are that way.
Yeah.
Yes.
So how you work with the assistants is possibly, I don't know, different than the way I work with the assistants,
I'm
right?
sure, I'm sure.
Now, Austin being, you know, Austin and having the technical skills that he has, you know, he does he does priming, he does pretty much everything. He has everything ready for us
Right.
by the time it's ready to go on, from setup and we double check everything, we'll look everything over, but, you know, they've been through some pretty intense training with us. I mean, our perfusion assistants are I hate to say it, but they're, I think, in many ways better than some of the foreign perfusionists that I go and work with in different countries when we're doing our mission trips and stuff. He's got plenty of skill. I keep telling him to get his degree and go to perfusion school, but I've been telling him that for 10, 12 years now, and I keep telling him. Hopefully one day he'll listen to me. You could maybe you could talk to him when he drives you home, and tell him, you know, maybe you ought to listen to Joe just once. It might help. But with that said, during the setup process, doing everything, did you find yourself spending more time checking everything? I mean, you do that on every case, but I mean, and
I did
this
check
is a
it
hard
and when you
question.
did say that. When you mentioned, let me interrupt you, but when you mentioned that, it did come to my head. Was 6 months ago, so I didn't really think of this, but I did check everything like a third, fourth time, and I guess I'm not sure that that's the right thing to do or the right answer, but it is true.
Yeah, I don't think there's any right answer. I think that's just human nature,
Yeah.
right?
Yeah, I did check everything a third, fourth time, which I probably wouldn't have done on any other case.
And so that brings me kind of full circle, and that's not just to you, it's to me too, right? It's all of us. You know, are we treating every patient on every day that we go to work the same as we would our either dear friend or loved ones? Are we? You know, and it gave me, you know, some pause.
Yeah.
Because I don't. I don't. I don't. I'm like, you know, oh, that'll be okay. We'll be all right. We can get around that. If it was on this case, I'd have been like, everybody stop. I want this changed. And that's all there is to it. You know? Now, I mean, does it clinically make a difference? No. Patients do. I mean, I'm not going to do something that would be in any way risky for a patient, but I have to admit, I do not on every given day act exactly the same way I did on your case. Now that could be because in your case, I failed to follow the rule, which I still believe I did fail to follow the rule of you treat everybody the same no matter who it is, because when you don't, that's when something's going to go wrong.
Usually.
So I think that's likely the reality versus the reality. But it gave me, I had to stop and check myself, dude, and say, you know, am I not giving somebody else the same level of service that I would give this person? And it made me really think. I think I give people incredibly good service, but since your case, I've actually become even a little more diligent because after 46 years of doing this, there is some level of, I talked about the swag, I got this, everything's fine, whatever. I kind of pulled back a little bit on that. And I'm hoping that's a good thing. I'm hoping. What about you? What do you think?
Yeah, I agree. I think it's a human nature factor in it. We like to think that we treat every case the same, but it's honestly not true sometimes, and someone or something like that. So, but not to say, as you said, they're not getting great service. They are. Everyone's getting great service. I really am confident in everything we do. I guess it's an arrogance that we may all have because we are really good at what we do. But, it's something definitely to think about that you think that, yes, that's true. But then when you're in the situation and actually dealing with someone you're like, well, is it true? So I think it's a great question.
Yeah, that is. Do we have any questions from out in the audience? Now, Peter says that he wanted to give an update. Audio, everything's perfect as far as that. No technical issues. He says this story is such an inspiration. He loves inspirational stories like this, and this is profound. Well, that's a pretty interesting comment. Since that comment is about this, and this program is technically about you, you want to talk to Peter?
Peter, it is profound. It's profound when it happens to you. Probably it comes home how we treat our patients. I think we all get caught up in the tinker toys of what we do. The mechanisms, the circuits, the prime, and
The essence pump.
right.
I love me some essence.
But sometimes we tend to overlook the fact that that person and their family are right on the edge of their existence. So yeah, it does make you think about things that you wouldn't otherwise. And I think it's human nature for you to second guess yourself. I think anyone would have done that. But at the same time, we spend our careers honing this rote memory of what we do. And we have developed, those who are successful have developed this bell curve of efficiency, where we're required to have some speed in what we do. And we try to accomplish these different things within said time and do it efficiently but effectively. So any deviation from that tends to kind of affect that curve, that efficiency curve. It's very easy, and I think it's just human nature. Yeah.
So now, since the operation, Clark, since you had this done, how do you feel? How's your energy level? How's your memory? Have you forgotten everything Diane ever did to aggravate you? Again, thanks to the bubbles. She asked me to do that, by the way.
First of all, my wife is a saint. She is a saint.
Angel.
Yes. But no, I feel very good. I have walked every day this week that I haven't worked. And I noticed I mentioned to Austin earlier today that I didn't realize there are certain places in my regular walk where I would have feelings of exertion.
Yeah.
And
Any lightheadedness, like just not feeling normal?
Not anymore. But I do realize now that before I had those. That I just thought they're normal.
Yeah. Yeah. Because it would resolve.
Right. They would resolve.
Yeah. So you just slowly adapted
Yes.
to this condition you had.
Yeah, I'm sure I have.
So you reached critical mass.
Yeah, I'm sure I have considerable collaterals.
Oh yeah,
You know,
absolutely, absolutely true.
Yeah, and so my physiology just compensated for it through all of those years. But it's remarkable that I got to age 70 before something happened.
So
And-
if I was going to ask, how may I, if you don't mind me asking, how old you are?
I'm 71,
71. Okay, so when was your birthday?
1953.
No, not the year, the month.
August.
August. That's another one of those bubbles.
Yeah, so it's coming up.
August. So you'll be 72.
I'll be 72.
Okay, so
yeah.
So 3.5. You're 3.5 years, basically 3.5 years older than I am. How long are you going to do this?
I still enjoy what I do. I love what I do, and I think, like I've shared with you before, I would miss probably the people that I work with, that I've come to know over the years. I mean, we know the names of each other's children, and they stop me to this day and want to see pictures of my new grandchild that's been born since my procedure.
Yeah.
So, God is good.
Yeah. Yes. Yes, absolutely. Absolutely. I agree with you 100% on that. I'm happy. I'm very happy to see you. I'm happy that you're here with us. And because I think it would have been just such an incredible loss at every level, because you are just certainly one of the kindest souls that I know, and well liked, well respected. You're in this community here, very much so. You have, whether it be at Luke's or Memorial or Methodist, doesn't matter which hospital you're at. Can we talk about which hospital you had your surgery? I don't think there's any reason why we can't.
I think I mentioned it, but
Yeah,
it was Methodist.
Houston
Hospital.
Methodist Hospital, the Woodlands. That's right.
Right,
And
right.
we do quite a bit of cases there. Dr. Lucas Duvall
Right.
was your surgeon.
Great guy.
Yeah, absolutely fantastic, excellent. This is an exquisite surgeon.
Right.
He
not
is
not
very,
just
very
as
good.
a surgeon, but as a person.
Yes, he is
Yeah.
genuinely a decent human being on
Yeah.
top of it. I
Right,
agree with you.
right.
But he is absolutely a very skilled heart surgeon. There's
Right.
a surgeon in general. I mean, he's just really good at what he does.
Mm-hmm.
And he's got incredibly good judgment. That's something I really like about him. So I wanted to ask this some question, and maybe you could talk with Austin about this, because you're still working. Now, albeit you do work at a reduced time,
Right.
right? You're 3 days a week, by
Right.
and large, and you still want to do what you're doing, but it's at a reduced capacity, which I completely respect and appreciate, and I hope one day I could get there too. And I'm trying really hard. But in the past, when we first started our practice, you started with us. We were solo all the way.
Right.
We would go in, we would set up, we would do everything ourselves. We would finish the case, tear everything down, do the paperwork, reset everything back up again, and move on from there. But somewhere along the way, I came to the realization, I was like that too. I came to the realization that, man, this is really hard. This is a lot. This is a lot.
Right.
And I started the HET, Houston Extracorporeal Technologies, name of our company, and the Perfusion Assistant Program. And Austin was our first one, and got him going to see. Basically, it was a what do they call that when you're doing like a trial run of something? What is that called? You know what I'm trying to say? Proof of concept.
There
Okay.
you go.
Yeah, that's what it was. Proof of concept. Okay, well, could this work? I mean, can this really work? I'm going to ask you, in all seriousness, if I had not done that, if our company had not evolved into that, and you had somebody like Austin or somebody like Ashley or somebody like Magic or somebody like John, who come in and do so much of all of this peripheral stuff that we do, got them lab trained, so they're certified to do that. They're privileged at the hospitals, and again, their training is exceptional. This isn't they aren't just knuckleburgers who don't know anything that's going on. I mean, if we were to fall out in the middle of the procedure, I don't think there's any question in my mind. I know the case is true in Austin, but they'd be able to finish the case. They would get that patient through that procedure. It may not be perfect, but with help from anesthesia, maybe some other people, with some of the stuff that maybe they're just not quite trained on, I think technically they could get the patient off pump and do it, and not just outright. At least hold the fort until somebody else could get there, right? Because we're by ourselves,
Right. That's
right?
correct.
But if it wasn't for that, do you think you'd still be working?
That's a good question. I am grateful to have all of these people there, not just because of their technical expertise, but I've gotten to know them very closely too. And I look forward to the different personalities where I can interact, with these people. Whereas before, perfusion can be a lonely job. We interact with the team and we know our cues, but after a period of years, you get to be, if you can rise to the situation, you get to the point where your surgeon and your surgeries, and you can get by with very little conversation. So it's always nice to have someone there to share with, and but to have someone skilled that you can share with, it's on a different level.
Absolutely.
And not just knows what but you can trust. So yeah, it does make a difference. It does make a difference. And little things that they do for us that used to weigh on your mind. You don't realize. It's like, okay, after the case is up, now I have to bag up the trash and find out where to put it. It's just little things like that. And
I think it's made an enormous difference. It's made a big difference to me.
And they are so willing to be helpful. And I try to find out what they like to do. When they will like to take breaks and go get a cup of coffee or something, and make sure that they get to do the things that. So it's like a team. It's part of the team, and they've integrated so well. I think that for anyone who has been a perfusionist, and I've had a couple of jobs where I was the Lone Ranger.
Well, our job was like that when you first came on with us.
Yeah. Well, it's not just that. By myself, all the calls.
Oh, yeah.
Everything.
Oh, that's crazy. Yeah, that's crazy.
Yeah, I'm the only
I've done that
perfusionist
too.
in town.
Yeah, I've done that too.
And so that's extremely lonely. So I have a very heightened level of respect and appreciation for these people. I think that it's commendable that they see this as upward mobility.
Absolutely. Where are you heading? I need to. Oh, okay. Well, we were just getting ready to close out, but here they're fixing Austin's microphone. So I'll let Austin get back. I know that one of the things that I've noticed in my rather long career is everything okay? Yes. So he's not going to come back? Okay. He had to go take care of something clinical, but that's fine. It is what it is. I'll close it out with this. You said something that struck a nerve with me, which was the loneliness part of it. I've been places where everybody's like, "Oh, you're perfusionist. You have it made. You just do your case. You out by noon with no balloon, and you're out on the golf course. And everybody wants you've got the best job. You don't ever have to do blah 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 blah." I hear it all the time. But when all hell breaks loose, everybody's just backing away from you and just getting farther and farther and farther away. And you need to get over here and hold this or do whatever the case may be and direct. And all eyes are on you, right?
Right.
Everybody wants our job until our job is no longer routine.
Right.
And then nobody wants our job.
That's correct.
That is a phenomenon I have seen very many times.
That's correct, because we are where the rubber meets the road.
Absolutely.
Yeah.
Absolutely. And you gotta have some tread. You gotta have some tread. Clark, thank you so much.
Thank you.
I appreciate this very much. Clark Milliken, dear friend, well-respected colleague, and I hope for many, many years to come. If I need my operation done, hopefully not. But if I do, I'm calling you.
You got it.
Thank you very much. I
Thank
appreciate that. Thank you. And we will see you all at 5 o'clock for some real science. We're going to have science, believe it or not.
No.
We're bringing in, yes, science, real science. We're bringing in Tabby, who, as you know, is in perfusion school now in SUNY. She's a perfusionist, PhD in physiology, trained by Dr. Navarre, who was trained directly by Dr. Guyton. Dr. Navarre is the former chairman of the Department of Physiology at Tulane.
Nice.
Tabby has a PhD in physiology with a focus on renal, and she is going to put to rest the idea that ultrafiltration causes renal failure. And I do have to ask you this. I forgot to do this. I know we're going over a minute. Maybe we'll go over 2 minutes. I ultrafiltrated the shit out of you, dude. Okay? They had pumped you bunch full of fluid.
Yeah.
And you were swolled up, man, by the time we got you. And your albumin was a little on the low side from dilution only, not from anything else, because you were well nourished, you didn't have a liver problem. But how are your kidneys?
Good.
Another example of my two eyes tell me that ultrafiltration doesn't cause, because I think I took 3,500 out of you. You were negative 3,500.
Listen, at my age, I have to wake up in the middle of the night and go to the restroom like you do.
Yeah, completely understand. That's for a different reason, Clark.
I know.
I think that's for a completely different reason.
No, there's nothing wrong with my kidneys.
Good. Sounds good. Well, I'm glad to hear that. But yet again, I know there are papers out there that say ultrafiltration is the devil and that it causes all these kidney issues. But no. It's nonsense. It's just not true. Now, if you desiccate the patient, if you take more than they have, I mean, obviously, yes, that'd be like being out in the middle of a desert without water, right? But that's not what we do.
Well, the largest argument I hear about that is that they feel like the hemodilution aids in the renal function postoperatively. I think creating a situation where you're not putting the patient on a roller coaster for their fluid, balance is extremely important.
You ultrafiltrate, I'm assuming.
I do.
You do, yeah.
I do. I pull it off like when we give Del Nido, and that's a significant amount of crystalloid going in a short period of time.
Yep.
I try to pull it off as I give it.
As opposed to letting it
Right.
sort of get absorbed into the interstitium.
Absolutely.
Because again, people don't keep thinking, well, it just gets in the skin. No, it gets in every organ. It gets distributed
Interstitial.
throughout the body,
Right.
right? And it can really cause, in its own way, organ dysfunction.
Right.
From just the organ being edematous. It reduces the perfusion to it. It reduces. It's just harmful.
You're
my
challenging.
view.
You're challenging the tissues.
No question about
Yeah.
it. I agree with you. But you have to correct the COP,
Right.
which we used to measure all the time and don't anymore. In fact, you talk to most perfusionists, they never look at the albumin level. And the albumin is obviously the best surrogate for COP if you're not going to measure COP directly. But that's something that I do frequently. It's what I think is very beneficial. Anyway, I know we ran over 4 minutes. The board won't give you any additional credit for it, but sometimes it makes up for the times that we have to end early. But once again, Clark Milligan, thank you very much.
Thank
I
you,
appreciate
Joe.
it. I wish
Thank
your
you.
lovely wife, Diane, would have been here. It would have been nice to hear from her as well. I know she's out of town at this moment.
I love her, but we would have never been able to talk.
That may be very true. That may be very true. All right, thank you. I'll see you at 5 o'clock this afternoon, Central Time. Remember that. And you got another comment from Andrew L. Thanks, Joseph. Good show. Well, I appreciate that very much, Andrew. Thank you. See, you didn't think anybody would be watching this time of the morning, but they do.
That's right.
Because we have a global audience. Believe it or not, dude, we are across. Magic can tell you a little bit more about this, but we're actually being monetized by YouTube now.
Wow.
We have so many people that watch our show now that we actually, now the check I got was only $1.47, but it's better than nothing. Okay, it was $1.47. I was like, look, they're showing advertisements now on our show. And this one, the one that they did this morning was from BetterHelp, which is for like, psychological counseling. And I was like, well, so appropriate for us. Okay, that's
right.
pretty good. Their algorithm apparently works because we're all crazy. All right, thank y'all. We'll see you at 5 o'clock. Peace out.